morning, good afternoon, or good evening. Welcome back to Bariatrics and Beyond, the podcast where we talk about life before, during, and beyond bariatric surgery. So grab yourself a healthy snack and a drink because on today's episode, we have Doctor Manoel Galvao.
Hi, Kayla.
Hello, welcome. How are you? Happy New Year.
Happy New Year as well.
Thank you. Thank you for joining us on the podcast. So for those of you who don't know we like to call you Dr. G because you're pretty cool guy. Like it's like you're the G. So Dr. G, can you introduce yourself and let us know, where you're from and your background?
Yep. So by birth I'm Brazilian. By life I'm a citizen of the world, and I'm a doctor, an MD. I have now 35 years. I'm graduated. I'm triple board certified in Brazil in digestive surgery, in gastroenterology, and in digestive endoscopy. And I have been developed the field of bariatric endoscopies in the last 20 years and doing a lot of clinical research.
That is incredible. So where do you reside now? Where are you?
Well, in the beautiful city of Orlando, Florida is where my base is right now, and where I'm passing quite some of my time now since working in US is kind of grounding. So yeah, I'm living in US right now, Orlando, Florida.
That's amazing. So can you tell us a little bit about your background in the bariatric community and how did you come to meet Dr. Ortiz and join the EOC group?
Well, Kayla, we have to get back like this 20 years ago. So 20 years ago, bariatric surgery was done basically open and was on the very fast transition to laparoscopy. And at that time, when we have a complication, the mortality was very high. Complication was very severe. Patients passed like months in the hospital. And we were developing at that time a very interesting kind of surgery that's called NOTES, natural orifice transluminal endoscopic surgery. And if I may, I need 30 seconds to tell you what it is that we are doing surgeries throughout the stomach, throughout vaginas and anus to reach the organs internally. And it was a very big research. And I'm seeing these cases. I was not in bariatrics that time. Then I was about to. And I jumped in with someone that you know, Dr. Ramiro Ramos. So we started the practice together in Brazil 20 years ago. And I was doing endoscopy and already putting my scope out of the cavities, human cavities, and was doing good. There's no complications. And I remember telling him, hey, what you're doing? Oh, this patient comes from helicopter to another hospital. It's very ill. We are trying to open up, wash, and then put them brains or whatever. And I say, hey, you know what? Everything you're doing, I can do myself, but by the mouth. So you have to travel throughout the abdomen. You can get to there. I'm just there. I can get my scope out. I can watch. I can put a drain. How about that? And they got together and thinking, so yes, let's do it. And it turns the game. And we started bariatric endoscopy by treating very severe complications of bariatric surgery. And we end up saving quite some patients, some lives at that time. And then it starts. And like, for example, the stents that we use now for leaks, they were never used for people that's supposed to leave. They were for cancer. But they say that we think out of the box, saying, let's use it. So we got permission from the patients, permission from the ethics committees, and because patients have basically no option. And we start doing that. And with that, we change the game. And then we help bariatric transits to the safety that you have right now.
That's incredible, Dr. G. You are such a pioneer. That's wow. That is so incredible.
It is a pioneer from the need. For example, I know that you have a surgery that is a sleeve. Is that correct?
Mm-hmm. Yep.
So sleeves bring another complexity to us. So we thought that everything was okay with bypass. And then comes the sleeve that's supposed not to have complications because of very simple surgery in the paper. But when you have complications, it was a different complications, different background, the way it happens, called pathophysiology. And we have to develop, again, new methods to treat those complications. So it was like says 2000, and the sleeve start 2005. We start treating them 2010 years after that. So we have to get to ourselves together and get out with solutions.
Yeah.
And interestingly, that those solutions that we developed there, like the procedure that Omino developed that in Brazil, was start being done all over the world, and we reproducing what we were doing.
It's incredible how bariatric surgery is just constantly evolving, isn't it?
Yeah. So can you imagine that by a bariatric surgery, such a complex procedure, now has the mortality and the complications of a simple gallbladder surgery?
Yeah. Isn't that
It's hard to
cool?
imagine, but it's safe.
Yeah, that is
And
so
we are
cool.
happy that we got to that.
Right. So let's fast forward. So you've come up with this fantastic idea. You're in Brazil. How did you connect with Dr. Ortiz and start practicing in Mexico? How did that happen?
Yeah. So I met the young Ortiz. I don't remember well. I think it was in Strasbourg. We have a training center there called IRCA. That now we are. I am one of the directors of courses and director of the one we just opened in December in India. And during this course, he told me, "Hey, I have this practice there in Tijuana. I dare you to go there and see. I'm doing good things there."
Yeah.
And wherever. And then I say, count on me. Just ask me, I go. And he said, he said to me, "You're never gonna go there. You're too famous." Or wherever. Say, "Hey, I don't play famous. I don't play doctor. I'm just the same person talking to you right now."
Mhm.
He said, "Oh, no, 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 no." He was like very shy. And then Dr. Ramos started working with him. And then sometime he gave me a call. "Hey, can you come here to Tijuana, let's talk, let's see what we're doing." So, and we spent the New Year's Eve together by his invitation in a fantastic resort in the Guadalupe Valley, where Tijuana, Baja California, have all the wineries and good wine produced there. And there I go and see his practice, and we set the deal and say, "Okay, if you think that what we are doing and what we are doing now is not just treating complications." So those 20 years, we have developed the field of bariatric endoscopy in the way that they treat obesity and diabetes. So we have the intragastric balloons that we develop and the endoscopic suturing that we possibly gonna talk about it later. And then yes, okay, I'm here with you. And he was like so surprised, so happy.
The rest
How
is
you know,
history.
you're doing a good thing. You are the highest volume on earth, and you are doing so responsibly,
Yeah.
with such a good success and such a heart and care of the patients. Is what I want from my patients.
I love that. But did you see what Dr. Ortiz did there? He invited you to Tijuana. He got you drunk. He took you to the vineyards. He got you drunk, and then now you're part of the team.
Yeah, the man got a plan,
He had a
Kayla,
plan. He
but
knew what he
get
was
me
doing.
drunk is mission impossible. On the other way, it's easier.
Right. That's awesome. So it's really cool because how often do you do surgery with us? Is it like once every few months or once a month for like a week or so?
Every 2 months, we are in Tijuana. Every 2 months, and spend 3 to 4 days there. And as any numbers of patients that what is necessary, we will be there.
That's
And
incredible.
for sure, they're gonna be a group treating the patients before and after there.
That's awesome. So you guys, when we say we have the world's best, the superstar, Dr. G, like we really, really do. You guys don't have to go to Brazil. All you got to do is just come to us and he comes to you. So we're very, very lucky and very honored to have you. So for people who are brand new to the bariatric community and don't really know too much about, all the different weight loss surgery procedures and they're hearing ESG or endosleeve or endoscopic sleeve gastrectomy, can you explain exactly what is the endosleeve?
Yeah, absolutely. The first thing that is very cool. So without opening anything, without cutting anything, we go by mouth using a flexible endoscope, and we have a suturing machine on the tip of the scope. And we're gonna do suturing on the stomach. We're gonna craft the stomach in a tubulized way, in a sleeve shape on that. And pretty much that's it. we craft a new shape of the stomach, and if that, we delay the gastric emptying, and we lead the patients to lose weight.
That's incredible. And so, who would be a good candidate for the endoscopic sleeve?
Well, that's nowadays that's $1 million question. So before was kind of very straightforward, but now we have all the buzz and the hype of the new ineffective drugs called GLP-1 analogs, very well known by the names Ozempic, Mounjaro,
Mhm.
and Zepbound. So they are very effective, and they are being used all over the spectrum of obesity.
Mhm.
And we know that obesity is a chronic, progressive, and incurable disease. There's no cure for obesity. There is control, like hypertension, like diabetes. You can control effectively, but you cannot cure.
Mm.
So I can tell you that our target and where the best results we can have is 30 to 35. The endoscopic sleeve gastroplasty, and we help that, and we participate in a big trial in US called Mary trial that end up with the FDA approving the procedure. So the procedure is approved in US as 2 years right now. So the approval is 30 to 50.
And that's
Okay?
BMI?
BMI,
Okay.
exactly,
Mhm. Yep.
indeed. So we have the best result, at least in our hands, in 30 to 36, 37. That said, we did a pioneer work in Mexico, India, and Brazil to lower that. So we published a paper in even lower BMIs, 26 and over. So those patients, just can you imagine, patients with just overweight, we can 80% of the patients have normal BMI after the procedure. So that's it. So the lower end of 30s, 30, 35, 37. That said, if so, the International Federation for Surgery of Obesity, like the global organization of bariatric surgery, just approved it as well, this procedure for obesity class 1, obesity class 2, 35 up to 40, or patients that don't want bariatric surgery, or they don't qualify because they have some clinical issues
Uh-huh.
that prevent them to have a surgery on that. And also, Kayla, we have a very good work that we do with Elias in Mexico, is that impossible BMIs.
Mm.
So as we pass by the mouth, we don't have any physical barrier. I just need to have someone to give a good anesthesia to the patients. So we do 90 BMIs, 110 BMIs, 120 BMIs. The intention on those patients is not for sure to control the disease, but to put the weight down that they can safely get the surgery that they need, because what we do don't prevent to have any type of surgery.
Yeah, that's incredible because I think just the general public and people who aren't too educated in bariatric surgery, they don't realize that, you can be too overweight to have bariatric surgery. And, you can have that high BMI. So this is definitely such a good option for people whose BMI is too high to have the typical sleeve or the bypass. So this is definitely a great starting point. And then also on the flip side, a lot of people's BMI isn't high enough for weight loss surgery, but they struggle with obesity and being overweight. So this is also such a really good option on both ends of the scale. So I that's what I love about the ESG. I love that about that. It just
Yeah,
opens the
absolutely.
yeah.
And also the patients they don't want. So in the patient, they qualify for bariatric surgery, but they don't want surgery. We are very sincere and we explain to them, look, you're not gonna have the results of the surgery. You're gonna help control your weight for a certain time. Is Are you okay with that? And quite some people are.
Yes.
And now even more, Kyla, because in this whole hype and confusion with GLP-1 analogs and so on, we also start a very pioneer work with Dr. Callejas, our nutriologist, the best in the world as well,
Yeah.
that we do our procedure and we add to this procedure just after the patients get out of the hospital, they start using the GLP-1 analogs, Mounjaro, Zepbound, and you know what? The results are the same of a sleeve gastrectomy.
Really? Wow.
Without the complications. The downside is the price.
Yes.
So our procedure is a slight more pricey because of the equipment, and also you're gonna add the price of the equipment. So as in life, everything is a balance.
Yep. Yep. So you said earlier, you don't have as many like restrictions having to go through areas in the body. So I know with the gastric sleeve, there's a very strict pre-op diet because the liver gets lifted. So is the pre-op diet similar for the ESG, or is it a little bit different, or how's that work?
Yeah, that's a good question. So in point blank, we ask the same prep of a bariatric surgery
Okay.
to not confuse, because a lot of people qualify for both and not. But truly, we don't need.
Really? But you know what, Dr. G?
I don't have the liver.
Yeah, right. Okay.
I don't see it.
Right. That's cool. That's cool. But you know what I think with the pre-op diet, it's such good preparation just to get your mind frame right and to introduce like the right type of nutrition and to learn how to kind of fuel your body. So I think it is just like a good practice for your new lifestyle anyhow.
Yeah, absolutely. And you can see that like I don't like to say test because we're not here to test anyone.
Yeah.
But can be like this. So if you can get into the pre-op diet, it means you're gonna get a good post-op diet. And it will
Exactly.
benefit a lot. Because for example, for surgery, you cannot eat solid right away because you can like open up the staples. With us, it's the same. I need patient with a little bit more on liquid diet than the regular like a sleeve. Like I need 4 weeks to 6 weeks on liquid diet and puree. Why? Because I cannot have pressure on the stitches that we do by endoscopy. It's a different reason. But that's very important. If you do a good pre-op diet, it means that you are prepared to follow the diet on the post-operative course of your procedure.
Okay, so the pre-op diet the post-op diet is a little bit more strict and the stages go a little longer. Okay, and then so for people who are watching at home and still a little bit confused, so the stomach is basically sutured, right? It's not actually removed, like the portion is not removed like it is in the sleeve. That's why you're able to go endoscopically and do it. That's correct?
Yeah, that's absolutely correct. So
Okay, perfect.
in surgery, you staple. Staple, you between 2 lines of staple, you cut in the middle.
Yep.
So in a vertical way in the sleeve, or in the like different ways when you do a bypass and then you have to connect to the bore. We, on our end, we go inside, so the stomach is there.
Yeah.
And it can be used to do a sleeve in the future, to do a bypass, to do a SATI, any procedure. So it's very versatile. The downside is that we are not as powerful as surgery and people cannot be misled to that. So we work with 15 to 20% of total body weight loss.
Gotcha.
And the durability of what we do, and I know is one of your questions, is that we prove that if we do it the right way, and that's have to be weight very well. So we are doing suturing. Suturing is crafting. So it depends on your stylist.
Right.
It depends on who crafts your beautiful clothes.
Yeah.
Can be good,
yeah,
or can open up.
Could be a hit or a miss.
Yeah. So I'm doing that for 10 years since we developed that. I have done more than 5,000 cases. So allegedly, we can suture well by endoscopy. So we got to a point that our personal results is around 3 to 4 years. 70% of the patients, they are on the target area that we have, that is 10 to 15% of total body weight loss. So it's different from surgery.
Yeah.
Surgery goes you to next level, 20, 30, 35% total body weight loss. So the patients have to wait this very well when they are deciding, and we are very transparent. You know me, we are very transparent about that. I'm not saying that that's the best thing, that you have to do that, but this is definitely something on the armamentarium, on this chronic disease, that we think that can help the patients.
Yep, I love that. And I've actually been lucky enough to go in the OR and watch you do in Endosleeve.
Watch me dancing.
Yeah, yes, exactly. It's like a dance, you guys. He's so talented. It's definitely something to watch. So can you let everyone know how long does it take to do the Endosleeve?
Oh, that's a very nice question. So every time I introduce myself to the patients and I talk to the patient and say, hey, the hospital has the time dimensions, and time dimensions are like that. So for me, it is 45, 50, even 60 minutes, below 1 hour. But that's me getting there and doing the procedure.
Mm-hmm.
For the ones who are waiting for the patient, it is forever.
Yes.
And for the patient itself, it doesn't matter.
Yeah. It's like 2
So that's
seconds.
how,
You're sleeping awake.
because you knock it out and you wake up and say, hey, what's happened? So I kind of I play with the patients and I make this joke to relax everybody. But yes, it's around an hour. And interestingly, Kayla, anyone that say that do that in 20 minutes is that it can be done with less stitches. So it's mechanical, it is
Oh.
mathematical. So
Yeah.
if I'm doing, and now I'm doing like 20 stitches per suture, this have a time that I cannot go faster than that.
Yeah.
But if I do less stitches, I can be the fastest in the world.
So with I know some people's stomachs are longer and stuff like that. So does the amount of stitches change per surgery for you, or is it just generally pretty much the
Yes.
same amount? It does?
It changed because the stomach have around 20 shapes. So it's basically a question. So you get inside the stomach and you have to understand the variables, the shape, how is the compliance. So we engage into the tissue with a corkscrew, like a corkscrew, and we bring the tissue in. So the tissue varies from patient to another.
Yeah.
So we can never say exactly what's gonna happen, is what I say to the patient. So depending what I found. Sometimes it's a gigantic stomach, we have to use 7, 8 sutures, and regularly we use 5 to 6 sutures. But there is some small stomachs. So, and the other thing is that we don't go as narrow as a sleeve gastrectomy.
Gotcha.
Some of my colleagues, they say that I go and do as narrow as possible. I don't believe that because it is gonna be a lot of tension. I just understand how is the tissue and I do a nice, good tube. We don't have any ways to measure that besides being visual.
Okay, so you don't use is it called a bougie? Bougie? You don't use that?
No, I can't.
Ah, okay.
I can't because I already have my scope as a bougie.
Yeah, that makes sense. That makes sense. And then you just
So it's
kind
gonna
of
be
freehand it.
competition on 2 tubes.
Yeah, that makes total sense. So you were saying that you tell the patient they're not even going to know. They're just going to be knocked out and awake. So for them, it's 2 minutes. So speaking of being knocked out, what kind of anesthesia do you guys use? Is it the same for the other surgeries?
Yeah, it's the same. It's general anesthesia. And the reason for that is that we have to protect the throat.
Gotcha.
Because we use a device called overtube. It protects, because my scope is a little bit bigger than a regular scope. So patients can have some sore throat that they last like one or 2 days. So it's to protect the patient. So it's going to be a competition to the airways. For sure, there are colleagues that don't use that. They pass directly and they claim that they can do that under sedation. But I am not comfortable with someone that's going to take like 32 minutes to 1 hour under sedation, because the most safe anesthesia is the general anesthesia.
Yeah.
But the difference is that this anesthesia is not that as deep as surgery, because we don't need like relax the muscles and some technicalities that is not needed. So it's a more, if I can say, a more not superficial, but a more light general anesthesia, if I can say that.
Yeah. Awesome. And then so let's talk about life after the ESG. I know with the bypass, you've got to be on vitamins for the rest of your life. For the sleeve, they say the first year. What is like the vitamin regime after having the ESG?
That's a very interesting one. So we don't take out any part of the stomach. We don't reconnect the stomach with the bowel. So we are not talking about malabsorption on that. But for sure, patients lose weight in a fast way. So at least initially, you might need some protein, my vitamins, but later down the road, no. No, the stomach is there. Everything you have is there. So it's one of the advantage of doing endoscopic sleeve gastroplasty. So less requirement in terms of diet and restrict diet in terms of absorption and vitamins and things like that.
Yeah, that's incredible. And so with the follow-up, do you just suggest like 3, 6, 12-month like lab works?
Yeah, yeah. The same of surgery, just to check out, because you did a procedure, not because the procedure requires that, but the things are like that. I cannot cut the patient loose because they're gonna think that's nothing happened. For us, it's very important because in the day 4 or 5th, you're not gonna feel anything.
Mm,
You don't feel we don't feel the punch
yeah.
of having a surgery. So you're gonna stretch, you're gonna go like this. The pain that is the shoulder pain, it lasts very few. So most of our patients in day 3 or 4, they can go to the gym.
Wow. Wow, that is
And
so cool.
and that's a good thing and can be a bad thing.
Right.
Because if you don't feel and don't understand that you can do, you might end up respecting. And if you overeat, the sutures can broke and you can lose the procedure right away.
Yep. So just because you feel like you're 100%, you still have to baby your new remodeled stomach. Yeah, just until it's fully healed. Even though you feel, I feel like that's what happens with like plastic surgery. At about the 3-week mark, you're feeling pretty good, but then that's when an opening will happen because you start doing more. But you just got to follow the post-op instructions, guys.
And you go to the sun and you have a sun bath, and that's not good.
Exactly. So, speaking of complications, are there far less complications with the ESG? And if there was a complication, like what would that be? Because there's no like leak tests or anything that you got to do, right?
Yeah, that's very, very interesting, Kayla. So any procedure in medicine leads to complication.
Yeah.
If the ones say that I don't have complications, it means that or you're not seeing your patients after the procedure or you're not doing the procedure. So the studies we have done, when we compare with surgery, we have less complications and less severe complications. But for sure they can happen. I'm passing a needle through the stomach. So we can have bleedings, we can have perforations, we can have infections. Leak is very, very unlikely that you're gonna have it. Regarding the leak test, we end up doing that because of the hospital requirements there.
Gotcha.
And it's very interesting because our patients on the line to get the leak test, when they see the other patients on laparoscopy, they say, hey, I'm better than those guys.
Yeah, because they're feeling fantastic.
Yeah, and it's something. But one thing we do is an endoscopy pre and post that that we do one of the few places on earth that we do for every single patient, so the patients can see the reduction of the stomach on that. So, but answer your question in a very objective way.
Mm-hmm.
The complications rate when you go to the literature was around 2.5%. The new results of meta-analysis is when we got all the papers published together, we put that and we develop a structured statistical method to balance and analyze them. So now is 1.25. Our personal records is 0.7%.
Amazing.
And I can recall and I can tell you the 2 complications that I have that require the patient to stay in the hospital or return to the hospital. One is internal bleeding,
Mm-hmm.
that we keep the patient in the hospital. We need to transfuse blood because it was some adhesion that we was not expected. And the other is a patient and we do that in a very severe patients, for example, impenetrable abdomens, impossible BMI. So this patient was a very complicated patient that the cardiac surgeons sent to us, and he was completely anticoagulated. That allegedly is one of the contraindications of the procedure. But we did anyway in a very controlled environment, and this patient ended up bleeding and we have to do a sleeve hysterectomy. So there are the two major complications that our series have, and it was not in Mexico, was in India and Brazil. For the patients that we have done in Mexico so far, knock on the wood, we have nothing. But let's analyze that. I have done more than 5,000 cases, and we have these two severe complications. So it's 0.000. It means it's less complicated than taking an aspirin.
Yeah. Wow. That's something, Dr. G. That's pretty awesome. So we know that other bariatric surgeries, they will resolve issues and comorbidities such as high cholesterol, PCOS, diabetes, and they help women who are struggling with like fertility issues. Is that the same kind of effects that the ESG can have?
Yes and no. So we just present in San Diego this year on the Congress of American Society of Bariatric and Metabolic Surgery, our first 1,000 cases that we done in India. So first 1,000 cases in Asia that we follow the patient for 5 years. And I can tell you that, yes, the resolution of we call comorbidities, that is diseases or medical conditions associated with the obesity that more than 150. So we have very good control, but it's different from surgery. Surgery has a metabolic component. So it directly influences in the hormones of the body. Ours is much simple. Patients lose weight. By losing weight, you ameliorate and you control comorbidities. But yes, 50% on diabetes, 65% on hypertension, 78% on sleep apnea, on the patients that effectively lost weight.
That's awesome. So can this procedure be reversed?
Yes and no.
Okay, I'm asking all the yes and no questions, aren't I?
It's my third yes and no for you.
Yeah.
Yes, because I can go there and I can cut the suture, stomach gonna be open. On the other way, that this procedure works because when you do the folding of the tissue, like here and here and here, you can see my hands, it's like an accordion outside. So I oppose the external layers of the stomach called serosa, one against the other. And after 1 month, I have some adhesions. So that makes the procedure less. So even if the suture is broke, outside we're still gonna have some fibrosis. So
Okay.
immediately if they go there and cut the sutures, this is not gonna be enough, they're gonna open. But after 1 or 2 months, there's still gonna have some fibrosis. But I can reverse the stitches that we have done, that's for sure.
Okay.
And the other thing is just not the reversibility, but how we are flexible. Because you still can do your sleeve hysterectomy, and you still can do a bypass, duodenal switch, SARIs, whatever procedure necessary, mini gastric bypass can be done because we are away of the suture line.
Oh, okay. So after you have the ESG, you can go back in and have revision. So you can do basically all of them.
Yes, and or revision, or we can redo it. So surgery cannot redo the exactly same surgery. We can redo that. So I have a patient, is one of my oldest patients now. She has 12 years. And we have redone her procedure 3 times
Oh,
in
yeah?
these 12 years. And she's with 24 BMI because she wanted to be like in the weight.
Yeah, yeah. So
It's like a LASIK. We can retouch it at any time.
Okay, I love that. You know what else I really like the idea of with the ESG? Now, I'm a sleeve girly. I don't ever want to, and this is really, I'm not sure why. I have to really unpack my thoughts on this and why I wouldn't want to go to a bypass if I did need a revision. But I think it's like the vitamin deficiency and the malabsorption. I don't know if I love that idea about it. But what I love about the ESG is that after the sleeve, if there is regain, you can then have an ESG as a revision option from the sleeve, right?
Yeah, indeed.
Yeah. So, because we hear a lot of people saying like, oh, can you do a re-sleeve? And they're like, well, there's not really like a re-sleeve, but in theory, the ESG would kind of substitute as like a re-sleeve or a retightening. Because, for example, for me, I am going on 7 years post-op. So I have lost a lot of my initial restriction. People say, my sleeve is stretched out. And I think it's like it's a muscle. So it can stretch a bit, but it will never be the same size, right? And so you can go in and retighten it.
We can, I call this a 360 world. The world is round for a reason.
Yeah.
So the surgeons, they're going to see the patients that can, the way can recur with our endoscopic procedures. And we definitely see the patients that after surgery recur the weight. So we can go and we can resize the pouch of the gastric bypass. We can resize the sleeve gastrectomy with suture. And even more interesting, Kayla, on sleeve is that first, the patient with sleeve, they are like highly educated. They wanted to keep their sleeve. They make the surgery in the decision that they wanted to keep it.
Mm-hmm.
So we help with that. And our initial results, because suturing on a patient with sleeves is recently new, so our older patients have like 3 to 4 years that we have done it, but the initial results are very good. So even better than when we revise a gastric bypass. So why? Exactly what you just mentioned. The tissue become lush, and the patient complain that, hey, more food is fitting here. And you do an endoscopy or X-ray, and they say, oh, your stomach looks normal. And you say, that's not. And we can demonstrate that because when we grab the tissue in a revision with the helix, the corkscrew, the tissue comes to us like a normal stomach. And it should not, because after the surgeon do a sleeve, the tissue is very tight. I cannot do that. But 2 years, 3 years after, I can do that in any patient of the sleeve.
Really?
And that's a new territory that we get into that. And we are initial publications. Our patients are doing very, very, very fine on that. And I like to say that it's not my experience, it's not what I do, is because, Kayla, you know us and you know me, every single word that come out of my mouth, I had published. So I mean, I submit myself and my group to the peer review. So our peers review our work, so we are we are transparent on our opinions. So on that.
You know what we call that, Dr. G? We call that, you've got receipts. You've got the receipts. Okay, so is there anything else that you'd like patients to know about the ESG, or if they're researching, weight loss surgery, or any kind of tips that you want to share?
Yeah, I do.
Okay.
I do want to express my empathy with this disease. It was of the worst disease of mankind. We are not prepared for that. We don't have defenses against this. This is a chronic disease, and no one can get into your shoes. It's a really, really nasty disease. It's not a place that anyone wants to be. But if you are there, be sure that we can help. But always think that it's never going to be a silver bullet. You're always going to carry the burden, and you have to take care of yourself and look for help at any step of the way. So please have my empathy, and we are here to help.
Dr. G, thank you for saying that. As someone who has struggled with obesity their entire life, there is no ending. Yeah, I've lost 200 pounds, but for example, even just after the holidays and being around all that food, it never stops. The thought of what am I putting in my body? Oh, I shouldn't have had that. Like it doesn't stop. And I think for the outside world and the people who have never struggled with obesity, they do view people with obesity as, lazy or it is your own fault. People do not understand that it is a disease, and it's something that we fight every single day, no matter if you lose the weight or if you don't. It is a struggle. So thank you for having the empathy and expressing that. I really appreciate that. Really do. Thank you. Okay, so you guys, I think that is all the questions we have for Dr. Galvao, but I learned so much today from you. So I really appreciate you being on, and I love doing this because I learn so much. So, yeah, a lot of questions have been answered. So, cheers to you, Dr. G. When are you in Mexico next?
Oh, I'm gonna be there in January.
January
And
what?
let me check it here. I
So
think it's
putting you on the
16
spot.
because yes, it's yes, so much things happening.
Yeah.
So yes, so it's 22nd to 23rd. I'll be
Ah.
there serving our community there.
Oh, we will look forward to seeing you then. I'll be there next week, so I think we'll just miss each other. So, but I'm sure I'll see you throughout the year, maybe the next TJ trip. But we appreciate you. Thank you for your time, and thank you for being a guest on Bariatrics and Beyond.